My name is John Bass. I'm a pediatric cardiologist at the University of Minnesota, the director of the Division of Pediatric Cardiology here. Bench to bedside, this has a fairly concrete and special meaning to me. I've been at the University of Minnesota for a long time, but about 15 years ago, I started working closely with one of the interventional radiologists here, Kurt Amplatz. And Kurt was looking at children who were born with defects in their hearts and thinking about some way besides a surgical procedure to try to correct those defects. But instead of doing it the way we used to do many decades ago, of taking something and putting it into human patients to see if it worked, the original idea here was to try to think of a model in which this could be tried prior to putting it into humans, and did what we would think of as being a feasibility trial, trying to see if the device would actually work for doing that. And when it appeared that he had a design that was going to work, the next step was to do something we call good laboratory practice, or GLP testing of the devices. And we had then a stable animal model that these devices, stable model of a defect in the animals, that these devices could be implanted. And we did a series of implantation of the devices in those animals. And this appeared to really work pretty well. So the next step was to think about, could this be actually implanted in humans, in children and adults who were born with a certain type of defect and opening between the collecting chambers of the heart. The submission was made to the FDA, and clinical testing was done in children very rigorously, looking very carefully for any side effects and looking to be sure that the device actually did what it was supposed to. And so there was actually a comparison between surgery, which was started here for this defect 60 plus years ago at the University of Minnesota, and this device that was now being used to treat these same types of lesions in patients at the University of Minnesota. So there was an actual one-to-one comparison there, and the device proved to be really successful. The advantage of this is that it's put in through a long tube or catheter, and the children or adults do not have to undergo opening up of the chest and placing them on cardiopulmonary bypass. The hospitalization is overnight instead of being several days in the hospital. There are no chest tubes. Obviously, everything that we do medically has some risk to it and the possibility of some complications, but in comparing to surgery, this turned out to be at least as good as surgery. And obviously for the children, major advantages that they didn't have to end up with a large scar in the chest. Everything was done through a small puncture wound in the leg, and although there is a little tiny scar there, most patients and parents are unable to find it after a few months. So to me, this is something where an idea started in Dr. Amplatz's mind. It was tested in the animal laboratory, the bench testing of this device, approved by the FDA, and then actually used at the bedside implanting this device in children.